Now I would like to introduce Dr. Professor Nama French Mbombo, who says I shouldn't introduce her, and I don't know how to do this, how to do this. Some of you might know Professor Mbombo as having worked at the University of the Western Cape for a while, long while. She also worked in local government and provincial government in Eastern Cape and KZN. She was, as Professor Gray has just said, the Provincial Minister of Cultural Affairs and Sports before this portfolio. Where do I go from here? Professor Mbombo is both a community and scholar activist and has worked in many capacities. And we have spoken, and so there's two heads. Of course, you can hear what she's saying here. Of course, she occupies a formal position as Provincial Minister of Health. But as I just said, we said we'd like a dialogue. We'd like a dialogue, an intellectual dialogue, a scholarly dialogue, a community activist dialogue. And she's going to be speaking, I guess, with both hats on, or more with the activist dialogue. Professor Mbombo, ladies and gentlemen.
Good morning, everyone. I want to acknowledge the people who are here, Professor Gray, Professor Ratele, and there's also other lists here, but I see some of the familiar faces here. I see the professors here at the front. Leslie London, Sine Guguduma, Rene Petlu, and all others that are here. Thank you for the invite, specifically from Nezi. Ms. Titi was, you can see a UWC trademark. So she was from UWC. And although she was in psychology in terms of where she studied, but also we also was one of our researchers in the Department of Nursing when we had the millions of monies coming from the Atlantic Philanthropy. So when she invited me, when I said, no, that's academic stuff, I remember I'm just a politician. She said, we are bomba, we are teen, so I must sort myself out. And then when I was reluctant, and then probably she picked it up that Professor Radela was also my colleague. We did a lot of stuff when he was at UWC. I'm not disclosing anything, don't worry. So for him also to make it a point that I'm here, but anyway, I'm here. Thank you for that. Because of the platform, I prefer not to come up and have a lecture, nor having a kind of imposing on you, and also not even being a politician, although I'll be using the political standpoint to advance my agenda, if I could put it like that. But firstly, where I see myself, because it says I must talk about reflection on the health services and delivery in the context of calls for decolonization. So I'm just speaking, but if you want a paper, I can write it. Probably they must just give me a slot from the office. I can write a paper and then I do the referencing. No, I could. I could. But now it's just because I want just to have a conversation so that, and I will leave you so that you continue with the debate. So in the context of health, health services are the government responsibility, but health is everybody's business. And therefore, that's why I see the importance of the presence, my presence here, or the government voice in this debate. Because we are not only the clients of the products coming from the universities, we are also the employers, but also we have to render the services. So whatever the decisions that are being made elsewhere, they will always impact on us. And therefore we cannot be the other. We're supposed to be the other within. So that's where I see myself. Also, in terms of what we are faced with, there is no way that we don't see our relevance in this. So we have to be responsive. So it takes the whole of society actually to render health. Those who are probably not familiar with the context of health in terms of the health system, World Health Organization talks about the building blocks, which is the health information. It's all these building blocks are systems on its own in order to strengthen the whole of the health system. So my work, or what we do, is based on focusing on these blocks, which they are systems on its own, which is, i.e., the health financing is a system, is also a building blocks, leadership and governance, the research and technology, human resource, the service delivery, medicines and all others. So it's come of all of those. So when we talk about the health, we have to make the point that all of these, we have to strengthen them. There shouldn't be any weakest link. And of course, there will be others where, like health financing, the issue of it will be influenced by the economy of the country. But within that system, within the government, we have to strengthen those. So my take for today, I only want to dwell more on the other two, the human resource and the service delivery. And then the others probably can explore later. At the time that there was the fees must fall, there's a debate on the decolonization of education and all of those. I was intrigued when the medical students from the UCT medical school, I think it was published in one of these media, I'm not sure about through the IOL, when they did mention that there is a need for the decolonization of the medical education. And also UCT, there was a time with the academics, I think Leslie was also part of that, where they did some, not sure protest, whatever, but they raised a voice about the issue of the decolonization, the Africanization, and all of those. And I've also picked up also from some of the students, the medical students at the University of Stellenbosch around that. And therefore, not only the government assists in terms of the bursaries for some of the medical students, and also all the health professionals, but also they, from the fourth year onwards, that's when they do their clinical placement at our facilities. Therefore, they are ours, but also we are also the client, as I indicated. So therefore, we cannot afford not to be a responsive government, because the students have spoken. And also, luckily, in the Western Cape, we have got a multilateral agreement and bilateral agreement with each academic institution. There are four: UCT, Stellenbosch, UWC and CPUT. They don't have the medical schools, but they are also the producers of other health alliances and also nursing and others. So we've got all of those. And one of the sections there, it talks about the transformation. It means that we have to make a point. In terms of the structures, I host the rectors, the vice chancellors, I think once or twice a year at our meeting, which it comes from the work that has been done at the dean's level of the other committee, the deans and my HOD. And there's work that is happening by each other areas. So by the time it comes to us, the vice chancellor, which and the chair, and then look in terms of how far are we with the agreements. So within the multilateral agreement, which all have signed, it talks about the issue of the transformation. And recently we review in terms of where we are. It's a 12-year agreement, which is we have to review in every 3 years and all of those. So with the decolonization call and all of those, that's why we said that in our next meeting, we should be able to look at this, but the discussion must begin at the HOD level and the dean's level in terms of that, because the students and some of the staff members, they've already spoken. So I think there was a time also in the social media, I think it was the medical students, I can't recall, when I also made some views where I asked, at what extent, specifically around the medicine, at what extent can you decolonize? Because our medicine has been westernized. too much. And also, medicine has got, is it 10 areas? 10 or 8? 8, see. So it's about 8 kind of the areas. So are you talking about the area related to the internal medicine? Are you talking about the area related to the occupational? Or are you talking about the area related to psychiatry, ONG, and all of those? What extent? Because it's difficult to talk for all of those, because each and every one, they've got their own views. And also, if we talk about decolonization of health services, of health, at what extent? For example, the government have got 12 health professional categories, 12 independently, 12 of those. So what are you talking about? Are you talking about the physiotherapists, the occupational therapists, the nurses, the orthodontists, all of those? What are you talking about? So therefore, it cannot be just an umbrella thing. It means that someone needs to take it up and identify which areas that one wants has to focus on, so that we, as the government, could be able to see exactly where we are. But nonetheless, if you talk about the HR, but I want to make one example. Also, I've mentioned about the issue of the HR. And also, I don't want to talk much about the Cuban model. In terms of the sending medical students there, but I'll mention it when I talk about the services delivered. HR, let's go to the HR. Just to make one example of the profession that I'm familiar with, nursing. When I read the history, nursing started through the missionaries. Missionaries, of course, the colonizers, if I'll put it like that. If they look at the history, it was about where they were responding to making Africa to be less barbaric and also more civilized, and therefore, nursing and teaching specifically, especially within the Black African communities, and therefore to come up with this kind of a profession so that they could be the ones who will be, the classy ones. For some of us who grew up in the townships, you'll recall that the school principal, when you are a nurse, is a person that will be recognized in the community, and then everyone will be going to there to ask someone to write applications and letters. So there used to be not only the voice, but the source, not only the source of knowledge, but it is that kind of that person that everyone will respect. And if she or he, it used to be she, the nurse at the time, says that you cannot wear this, it means that it is right. So now you can understand this kind of what we are battling with when it comes to the top-down kind of the approach where, hey, mama, I say that you cannot have 10 children because I say so, irrespective of what. And noting where it came from initially through Florence Nightingale, the UK, which it started as responding to the issue. It was military in terms of the soldiers. So that's why I've got the epaulets, like in the army and all of those. So it was that kind of a context. Hence now when it becomes transplanted to this side, it becomes militarized. So you can understand at the time for us who were student nurses, when we are approaching a passage, the people will say, yeah, nurse, stand right there. Wait until I approach that passage. I'm approaching that corner. That kind of a thing. I'm aware that even in the military hospitals, there is still some kind of correctional service of seeing most of the military aspect of it. So when I normally make an argument, why the staff attitude, of course, I'll say there's not only the nurses, so look at also other health professionals. But we'll find that within there's that kind of issue of the bullying within the profession. I'm not saying about the others. I'm sorry because I'm familiar, I'm a nurse. So that's why I've got an authority to talk about it. So in case someone says that, how dare minister talking about nurses, I am a nurse. So so at what extent now can we, I don't even want to say decolonize or uncolonize, I don't know, in terms of how, because we'll not be able to go back there, but as service providers, how can we ensure that that kind of the embedded, the values that we transplanted as part of the nursing, the demilitarization of the nursing and whatever, all of those, at what extent can we do such of those things? And That's why I'm making this argument that the academics themselves, that's why they have to start from there because we absorb these health professionals. So within the curriculum, within the teaching approaches, within everything, they must be able to look at this at their level, in their context, so that whoever their products that we absorb, we look at these kind of things in order to resolve some of those. And same as with the issue of the multilateral agreement, as I indicated, that it does talk about the approaches, the curriculum, the services, and all of those. At what extent then can we be able to put more meat in those skeletons around that? Going to the issue of the service as part of the building blocks. I mentioned something about the students, medical students, throughout all other provinces that have been sent to Cuba to be medical doctors because of Cuba with its strength of the primary health care, except the Western Cape. There's no debate about the importance of primary health care. There's no debate. We all have an agreement, and everybody all agrees to the universal health coverage. Remember, I'm not talking about national health insurance. I'm talking about the universal health coverage, because not only is the right thing to do, but the issues of the equities, the social injustice, and all of those that impact on health, no person will disagree on that. Actually, it's going towards the international norm of accepting those issues. And therefore, but you'll find that within the medicine, as part of the, although we talk about primary health care as an approach, and it's also a South African approach, but you'll find that within the area of medicine, it becomes, there's also a tension among the public health people versus also the others in terms of the medicine. So again, that needs to be sorted among themselves. But for us as government, what we have done in terms of responding to such, instead of focusing on the individual, because there's no way you could be able to treat illnesses, because even for those, even to treat using the curative, because you always have new illnesses or new diseases, and always will have those. For example, we thought that TB, we managed to fight it. Yes, we have reduced whatever issues of the TB, but now we've got the total resistant TB where you cannot treat, and the people are still walking. So if you're going to be focusing only on the illnesses, you'll never be able to manage everything. Hence, for us who are using the population-based, which is the public health approach, in order to look at all of those. If you look at the quadruple burden of disease, the chronic conditions, which is the diabetes and the hypertension, therefore HIV/AIDS, the mental health, maternal and child health, and then the interpersonal violence and assault. It's part of those. But how do we respond to such? Using the population-based, and also using the issues that will underpin the principles of primary health care, which is related to responding to the social policies, to the equities, to the upstream factors, and all of those. How do we respond to such? So for the Western Cape, we're focused on the population-based, and also acknowledging the fact that the issues of community participation and involvement, the voice of the community, stroke the patient, and intersectoral collaboration, because health is everybody's business. It's not, we are only responsible for health services. But back to the decolonization debate now, why you selectively talking about primary health care in Mbombo? What about others? Because in terms of health care, we have preventive, promotive, curative, palliative, and all of those. Rehabilitative, there are those. Why primary health care? I hear reclaiming, probably I was going to say epistemological space. Let me leave that. I'm not an academic. I'm reclaiming that space of the primary health care, because you are sending them to Cuba to learn about primary health care, but from evidence in front of us. Actually, primary health care, it has always been an African thing. In South Africa specifically, 1940, the Polela model, Professor London, yes. It used to be my colleague. So that's why I always reflect, because we did a lot of projects together. But nevertheless, Polela model, Polela was a health center in KZN, I think it's in the Sisonke Justice. That's where in 1940 to 1960, for example, where it started with a community-orientated primary health care, where the focus was working with the civil society, with all of those, and it was successful. But coming from 1948, when apartheid started, that's when now it was completely, things changed to focusing more on the curative, on individual. Yet it was more of where the community base, everyone has got a role, the families have got a role, and then we've got a health center and all of those. So that's why I make an argument that we don't even need to send people to learn primary healthcare elsewhere. Of course, they did very well in other areas. Yes, Cuba, you remember the China with the barefoot doctors projects and all of those. But if you look in terms of it's not only about primary healthcare, but also primary care with a Polela health model in the case at that time. And it was on population base, and they were focusing on the upstream factors, the social determinants of health. And in terms of the African tradition, we know if you've got a headache or you've got a stomach ache, we don't only focus on your stomach ache. We will speculate that there are other reasons that you have got that headache. Probably maybe liso, you ate something, someone is bewitching you, or probably you need to slaughter a cow. There will always be other factors behind your illness. It's the same. So we not only have TB just because you have been delinquent, but it might be because of the overcrowding, it might be because of the food access, it might be because of the other things. So it goes back to the social determinants. It goes back to where us, we have to look at the upstream factors. What are the contributory causes? Provincial Strategic Goal 3, under the Provincial Strategic Plan for the 5-year period that we're in government, it talks about increase wellness, safety, and tackle social ills, which is the one that I chair, and now we're doing transversally because, as I always say, actually the policy, international policy says that health for all, all in health. So it's something where in every policy in government, in everything that you do, in any other way, whether in social development, whether in police, in social justice, whether in housing, there should be element of health within there. So therefore, that's why I said when I started that we need to work transversally and then look at the root causes of all of those when we render our service. Because for me, I won't be able to, I cannot keep on mopping the floor. We need to close the tap elsewhere. Closing the tap, it's about looking at the upstream factors. And example of the projects that are within that PSG, for example, is one of those is the men's dialogue. Never in health, you could have something like a men's dialogue. A men's dialogue, it's normally used to be part of the other, social department and all of those, men's dialogue. Because what I found that one quadruple of disease, which is the assault, interpersonal violence, and all of those. It's not about, whilst you say that, oh, they are drunk and whatever, all of those. But sometimes you hear the other side. You have those kind of conversations with men. Same issue with the HIV/AIDS, because you can tell the woman that, oh, please use condom and whatever, but at what extent that woman can be able to negotiate safe sex with that man who still upholds the patriarchal views and all of those. And in the context of where they don't have access to employment and all of those, and then they want to use their masculinity or manhood in order to fight these battles. Therefore, back to the basics. So that's why you will see myself in Nyanga, the Guguletu, the Ocean View, and discussing all of these with the men's dialogue. And then it comes up with various ways of doing it. 5 minutes? Okay, yeah. So ways was where you talk about the men in the cave, and they talk about their own issues without the presence of women, and they open it up. The Braai kind of area where we talk about the issues of them drinking and all of those kind of things. So same issue with the young women and girls, where we have started now at the primary school level, grouping them, higher primary school. Never in health where you can even go to the schools. You just wait and wait until people are patients, and then they come to the health facility, and then that's when you start treating the disease. But now we say, let's go and close the tap and go back to the communities and where they belong. Now, lastly, we know of the Traditional Health Traditional Practitioners in terms of the Act. It started, I think there was a 2007 where it got paused and then it was resuscitated again so that we recognize other health professionals, other professionals or other workers that need to form part of rendering the health services. Because in terms of the National Health Act, it's only those people who are accredited in terms of the health professional councils or nursing council or allied health act and all of those psychologists who will be participate in health. Yet we do know that in terms of that, because Minister Motsoaledi at the time, it was still saying I think last year he was waiting for the traditional council to come up and make a suggestion to the government in order for them to recognize. Because remember they've got the groupings, they've got the divine services, you have their description of the traditional healing or practitioners. Divine services, you've got the groupings of the traditional birth attendants, the traditional surgeons, the herbalists. So who should we put within? Because even with a divine, for example, like there was a debate in the Provincial AIDS Council in terms of where we can use to manage HIV/AIDS, but using traditional healers. Because I said we need to redefine, because within the divine, they talk about love portion. At what extent can love portion be used in terms of that I love you and whatever, therefore I pray that you won't have HIV/AIDS, all those kind of things. So they need to define themselves. For us who are open, but they need to define themselves so that they could form part of the health system. So with those words, I'm leaving you with continuing with the debate and then also looking at other aspects of the building blocks for health, not only the HR and the services and all others. Thank you.
Thank you. You don't want to take 5 minutes? Okay, thank you, Professor Mbombo. We can take about 5 minutes of interaction before Professor Mbombo leaves.
No questions?
Nope, that's fantastic.
So I was talking like a politician, nonsense.
Thank you, ma'am. Please, we have some gift. We always have to have a gift. I love this from Louise, by the way. I love flowers. It's not a gift, but it's great.
You're colonizing
okay,
me again.
Thank you.
Ladies and gentlemen, I'd just like to tell you why it was very important that she comes, other than the fact that she is the most well-versed person to speak. When I came to Cape Town the first time in 2004 and did my first year, she was the first person that I knew who obtained a PhD degree. And she made sure I come. And since that time, I had it in my mind that as a black young female coming from the Eastern Cape, that obtaining a PhD is possible, and indeed it is.
Young. Young.